Hello, my name is Dr. James Rubenstein from the University of California, San Francisco. It is my honor to present on primary central nervous system lymphoma on behalf of the Lymphoma Research Foundation. The objectives of my presentation today are to discuss the biological principles of central nervous system lymphoma, to assess the implications of emerging clinical trial data regarding CNS lymphoma treatment, and to identify strategies to address particularly complicated cases of primary central nervous system lymphoma. It is important to remind ourselves that primary central nervous system lymphoma is a extranodal variant of diffuse large B-cell lymphoma in the vast majority of cases. Most B-cell lymphomas are generated likely as a consequence of genetic mutations which occur during normal B-cell differentiation and adaptation to antigenic presentation. In normal lymph nodes, B lymphocytes are located within these germinal centers. Here they encounter antigens presented from the periphery, transported to these lymph nodes by macrophages. Antigenic presentation stimulates a process called somatic hypermutation in these B lymphocytes. This controlled mutational process enables the generation of novel, specific immunoglobulins or antibodies, which are capable of eradicating pathogens such as SARS-CoV-2, bacteria, viruses, funguses, cancer cells, etc. Because of this ongoing controlled hypermutation, there is a risk for deleterious mutations, which can give rise to uncontrolled lymphocyte growth. This leads to the lymphomagenesis, the generation of large cell lymphoma, for example, as shown in this histologic picture here on the right. You can see this disorganized collection of cells which are not engaged in normal immunity, and this is the basis for cancer. These cells have uncontrolled growth and disseminate within the body. Whereas on the left side, you can see a germinal center pattern of lymphocytes within a lymph node, and here they're highly organized, orchestrated to generate high affinity antibodies. But here it's likely, we believe, that deleterious mutations which occur over time with chronic antigenic stimulation, mutations occur that lead to uncontrolled growth of lymphocytes, leading to lymphomagenesis and cancer, as shown on the right side. So what are these mutations that underlie the generation of large cell lymphoma? This is summarized in this table here. The most common mutations, which we think are important in lymphomagenesis or in large cell lymphomagenesis, are highlighted in these red squares in this table. BCL2 is mutations which lead to upregulation of BCL2 via 1418 translocation, prevent programmed cell death, and stimulate longevity of lymphocytes, so this lymphocytes do not die. This is one of the key principles of cancer, the ability to withstand pro-apoptotic or pro-death stimulation via chemotherapy. Upregulation of the MYC proto-oncogene via the 814 translocation. This leads to uncontrolled proliferation and genomic instability in these cancer cells. Mutations involving the CD79B component of the B cell receptor are important in about 18% of lymphoma cases. And this leads to uncontrolled stimulation of the NF-kappa B pathway. And similarly, point mutations involving MyD88 proto-oncogene also stimulate NF-kappa B, and these are occur in about 29% of systemic large B-cell lymphoma cases. So what is different about primary central nervous system lymphoma? Well, many of these same mutations are present in these key mediate oncogenic pathways, such as CD79A and B and MyD88, leading to activation of the NF-kappa B pathway. Yet there are other stimulation for stimuli for the NF-kappa B, including the activation of BTK downstream, CD79A and B, protein kinase C. JAK-STAT pathway is likely important in upregulation. Activation of PIM kinases are similarly important, leading to activation of NF-kappa B, a key transcription factor located in the nucleus, which has key target genes, including BCL2, XBP1, and IRF4. And activation of this pathway leads to uncontrolled survival, proliferation, and invasion of lymphocytes. And this is the genetic basis for lymphomagenesis in a significant fraction of large B-cell lymphoma cases, in particular the primary central nervous system subtype. So it's been shown through meta-analyses that mutations involving CD79B and MYD88 are enriched in primary central nervous system lymphoma compared to nodal ABC diffuse large B-cell lymphomas by approximately twofold. So these primary CNS lymphoma is truly a disease in which activation of the NF-kappa B pathway seems to be a key driver for its pathogenesis. So there's great interest in targeting MYD88 and CD79B proto-oncogene pathways with therapeutic interventions to antagonize NF-kappa B activation to slow lymphoma growth. So clinically, primary central nervous system lymphoma is a disease in which there is dissemination within the neuroaxis. That means that the disease is predominantly limited to the brain, the eyes, the spinal fluid. And this is shown in this slide here, showing the left panel space-occupying, contrast-enhancing lesions involving both frontal lobes in this patient, as well as the parieto-occipital lobe and the contralateral side. So this multifocal disease, this contrast enhancement shows disruption of the blood is a manifestation of disruption of the blood-brain barrier. In 20% of cases, there is concomitant involvement of the retina and the other compartments within the eye, as shown by fundoscopic examination and ultrasound, showing deposits of tumor cells on layers in the retina. In 10 to 20% of the time, patients can also present with concomitant involvement of the fluid surrounding the brain, the cerebrospinal fluid. So it's important to evaluate each of these compartments, cerebrospinal fluid in the eyes, in every patient that's diagnosed with lymphoma in the brain. We also stage lymphoma, look for lymphoma outside of the brain in patients that present with lymphoma within the brain, because approximately 10% of the time you can identify lymphoma cells in the bone marrow or peripheral blood, and this is a different disease. We would term this disease as stage 4 diffuse large B-cell lymphoma with synchronous or concomitant brain involvement. And in my opinion, this requires a completely different treatment approach compared to primary central nervous system lymphoma. So in autopsy studies performed by our group, we found that CNS lymphoma is often a whole brain disease, not always, but we can identify at end-stage cases evidence for dissemination in multifocal sites. And we've shown by whole exome sequencing that each of these lesions have distinct genetic mutations compared to that are unique and are different from the primary lesion at the time of diagnosis. So there's adaptation and ongoing somatic hypermutation occurs with disease progression. So in terms of treatment, the standard treatment for CNS lymphoma has been based upon this principle that this is a whole brain disease, and therefore whole brain radiation has been one of the fundamental therapeutic approaches that's been used for many, many years. And this is in the 1990s, late 1980s and 1990s, pioneering work by Lisa DeAngelis and Memorial Sloan Kettering showed that combined modality therapy using methotrexate in combination with whole brain radiation was feasible and could likely prolong survival in many patients. And the Memorial Sloan Kettering regimen evolved to include high-dose methotrexate plus intrathecal methotrexate in combination with the CNS penetrant alkylating agent procarbazine plus vincristine. This is followed by a whole brain radiation. And you can see when this intervention was piloted in multi-center evaluation involving 102 patients in RTOG 9310, you could see that the median survival was 24 months, which at that time was quite considered to be quite an accomplishment. Yet the Kaplan-Meier curve shows no evidence of a stable plateau, neither in terms of progression-free nor overall survival. Indeed, the majority of patients show evidence of neurocognitive deficits, and many succumb to neurocognitive injury by after 1 or 2 years, and this is maybe the basis for why many of the patients succumb have late onset mortality. The median survival with combined modality therapy seems to be about 12 months. So many groups, including the Memorial Sloan Kettering group, have demonstrated that cancer, that whole brain radiation is associated with major neurocognitive deficits. This is manifested in 2 patients, which shows the effects of, in which the MRI show the effects of delayed neurotoxicity of whole brain radiation. The patient on the left is a patient with primary central nervous system lymphoma who was diagnosed at age 52. She ultimately required whole brain irradiation to control the disease. And you can see 5 years later, there's significant, on MRI, there's significant volume loss, white matter disease, and the patient shows many of the archetypical manifestations of late onset delayed neurotoxicity from whole brain radiation, including memory deficits, apathy, impaired concentration, gait disturbance, and incontinence. Whereas the patient on the right, who was 10 years older, did not receive high-dose whole brain radiotherapy as consolidation. This patient received high-dose chemotherapy and autologous stem cell transplant. The patient on the right shows none of these radiographic features. There's minimal volume loss, minimal white matter disease on the T2 flare images, and this patient on the right enjoys a normal quality of life. So there's clear evidence that whole brain radiation is clearly associated with the onset of delayed neurotoxicity, and this is an area of important research to identify mechanisms of neurotoxicity and to try and come up with interventions that avoid the neurotoxicity associated with treatment. So it's been known for many years, since the 1980s, that high-dose methotrexate, doses greater than at least 1 gram per meter squared, ideally greater than 3 grams per meter squared, associated with significant activity in diffuse large B-cell lymphoma in the brain. And several different induction strategies have been incorporated, including methotrexate plus rituximab, methotrexate plus temozolomide and rituximab, as we discussed, the Memorial Sloan Kettering induction, which uses procarbazine and vincristine plus rituximab plus methotrexate, and then methotrexate, cytarabine plus thiotepa and rituximab, the basis for the matrix regimen, which has been pioneered by the IELSG and Andres Ferrari and Gerald Illerhouse. It's been recognized, importantly, that when one gives doses greater than 3 grams per meter squared, at least in retrospective studies, we do not need to give concomitant intrathecal methotrexate. The advantages of high-dose methotrexate over intrathecal are, number one, you get sustained toxic levels of methotrexate for greater than 24 hours when it's given intravenously, because of the high concentrations that are achieved with high-dose methotrexate, gram per meter squared dosing administered intravenously, as opposed to intrathecal methotrexate, in which milligram doses are administered, and most of the methotrexate egresses out of the brain microenvironment within 24 hours. So cytotoxic levels are not achieved beyond 24 hours with intrathecal methotrexate. For this reason, we believe that high-dose methotrexate has a greater efficacy based upon its superior area under the curve in pharmacokinetics compared to intrathecal methotrexate. Moreover, intrathecal methotrexate may be associated with occasional high peak levels, which can be associated with episodes of neurotoxicity and stroke-like symptoms on a very rare basis, however. It's been shown for many years that established for many years that rituximab, which is a cornerstone of treatment for systemic large cell lymphoma, which is associated with a prolongation of survival, improvement in survival in systemic large B-cell lymphoma. Rituximab has poor CNS penetration, however, in central nervous system lymphoma. So there's been great interest in its application in primary CNS lymphoma. Yet, despite the fact that very little of it penetrates the cerebral spinal fluid, less than 1%. For this reason, our group has done some pioneering work looking at intraventricular administration of rituximab in a number of multi-center phase 1 investigations, looking at rituximab monotherapy, rituximab in combination with methotrexate and with lenalidomide. We were able to show that rituximab, as administered intra the CSF, is highly active in eradicating lymphomatous meningitis in the CSF, shown by these flow cytometry plots gating on CD19 positive B cells, and also effective in eradicating lymphoma cells within the brain, shown in deeper structures within the brain. So CSF rituximab actually likely penetrates brain parenchyma to eradicate lymphoma within deep brain structures. And this is consistent with the concept that there are enough immune effector cells that can mediate able to mediate rituximab-dependent antibody-dependent cellular cytotoxicity. So in systemic lymphoma of the brain, primary central nervous system lymphoma, there have been 2 randomized trials that evaluated the role of intravenous rituximab in the upfront setting in newly diagnosed primary central nervous system lymphoma. The results of the ILSG32 randomized trial favored slightly the role of rituximab in terms of improving progression-free survival. However, the recent studies led by Bromberg et al. In the HOVON ALG trial showed no impact of rituximab on event-free survival. So how do we interpret these discordant results? Well, one idea is that the possibility that the regimens are different and dramatically different in these 2 multi-center international trials. The MBVP regimen is highly distinct from methotrexate, Ara-C, and thiotepa, which is has much stronger alkylating agents. Another interpretation is that perhaps the effect of rituximab in the brain is less profound than rituximab is systemically, which makes biological sense. So we know there are certain fixed challenges in terms of this macromolecule of 140,000 Daltons penetrating the blood-brain barrier. Therefore, experts have concluded there's less certainty that rituximab plus high-dose methotrexate improves progression-free survival in newly diagnosed primary central nervous system lymphoma based on prospective clinical trial data. So here's an example of one of our patients that illustrates the issue of the limitations of induction therapy in this disease. This is one of my patients who is 65, presented with these large multi-centric contrast-enhancing lesions involving the frontal lobes and the parietal occipital lobe. After 8 cycles of methotrexate, temozolomide, and rituximab, there's a small area of residual enhancement in the left frontal lobe after MTR induction, which was not responding to, which did not respond after 6 cycles of methotrexate. So this is a fixed area of concern. The persistence of contrast enhancement meets the criteria for active or persistent lymphoma. So what is the next step in this situation? One could observe, one could apply whole brain radiotherapy, but we're aware of the data of neurocognitive deficits associated with whole brain radiotherapy. Another option is non-cross-resistant chemotherapy, including autologous stem cell transplant using CNS penetrant drugs. Biological agents, which have been shown to have activity in central nervous system lymphomas, such as lenalidomide or ibrutinib, or stereotactic radiosurgery, or focal radiation, including gamma knife. So therapeutic approach that we follow, it will be described in a moment. I want to cover consolidation strategies in general as an important concept in this disease. Whole brain radiotherapy can be divided into both standard doses involving 36 to 40 gray of whole brain radiotherapy. This dose level is most strongly associated with delayed onset after 1 year, late neurotoxicities such as brain atrophy, leukoencephalopathy, broad-based gait, incontinence, short-term memory loss. The NRG 1114 study has also evaluated reduced dose whole brain radiotherapy at 23 gray, and preliminary evidence in a smaller study in which most of the patients were aged less than 60 showed that limited evidence for neurotoxicity with this approach. So that it may be a promising approach to reduce neurotoxicity and still get the yield, the gain of the application of radiotherapy to eradicate residual lymphoma. There's also approaches with non-myeloablative therapy, high-dose RC or high-dose RFC, intensively administered plus infusional etoposide, EA consolidation, which has been studied in the 50202 trial. And then there's great interest in the application of a high-dose chemotherapy and autologous stem cell transplant involving at least 3 different preparative regimens, which are popular. Thiotepa-carmustine, as evaluated in the IELSG32 trial, thiotepa-busulfan cyclophosphamide, as evaluated in the PRECIS study, and BCNUV P16RC, melphalan, which has been studied, the BEAM regimen, which was initially studied at Memorial Sloan Kettering with not very promising results, but which is a standard regimen for systemic diffuse large B-cell lymphoma. It's important to note, though, that in the dose of RC in the BEAM regimen is less than 1 gram per meter squared, likely is not CNS penetrant, and melphalan has limited CNS penetration as well. So just to summarize the studies with low-dose whole brain radiotherapy as consolidation, this is evaluated in the NRG 1114 trial. Here, patients that achieved a CR to RMPV chemotherapy went on to receive 23.4 gray whole brain radiotherapy. This is associated with very promising 2-year progression-free survival, and as rigorously assessed favorable neurocognitive outcomes compared to the delayed effects of whole brain radiotherapy when administered at 36 to 40 gray. However, the median age in this trial was only 58, and only 3 patients were aged greater than 60, as I mentioned earlier. So that's a major limitation of this data, because most of the neurotoxicity occurs that's been described occurs in patients older than 60, and this is a disease whose incidence is increasing in persons aged greater than 60. So our group has been interested in dose-intensive consolidation for many years, and one of the consolidation approaches which we studied has been the EA consolidation, which involves infusional etoposide over 96 hours, plus high-dose RC administered twice daily for 4 days. This is the 50202 regimen, which is a consolidation applied after MPR induction. We showed a multi-center evaluation in CLG 50202 that we were able to achieve evidence of a stable plateau in terms of progression-free survival and overall survival, avoiding whole brain radiotherapy for the first time in multi-center evaluation in a clinical trial in this disease. So it seems that a significant fraction of patients may be cured with a median follow-up of greater than 4 years, and there's no evidence of delayed we saw no evidence of delayed toxicity or late on there's the stability of the Kaplan-Meier curve is encouraging. These results were confirmed in routine clinical practice as described by Burson et al. In a study in France, in which the median age was 60, age 39 to 77-year-olds went on to receive EA consolidation after MTR induction, and the Kaplan-Meier curves look very similar to 50202, with 0% treatment-related mortality during the consolidation phase with EA administered after MTR induction. However, it is clear that EA consolidation is associated with significant myelosuppression, and patients that receive this consolidation approach require inpatient hospitalization for monitoring and early intervention. a more recent study led by Caroline Sustained and who in the French group evaluated the PRECIS trial, which is a randomized phase 2 trial that evaluated whole brain radiotherapy as consolidation versus autologous stem cell transplant. Here, patients received the RMBVP induction, which consists of methotrexate, rituximab, BCNU, VP16 plus prednisone. So it's unique in that BCNU is incorporated up front during induction with etoposide and methotrexate. And then patients that did not progress went on to receive consolidation, either 40-gray whole brain radiotherapy or a very aggressive stem cell transplant preparative regimen, the TBC preparative regimen, consisting of thiotepa, busulfan, and Cytoxan. And here, the results presented in Kaplan-Meier form show that there's a marked advantage in patients that went on to receive a stem cell transplant. In the stem cell transplant patient arm was associated with a 2-year progression-free survival of 70%, compared to a rate of only 58% in the whole brain radiotherapy arm. So the curves are clearly distinct, with a median follow-up of 33.5 months. And the event-free survival similarly favors the TBC regimen. However, it's important to note that the TBC regimen was associated with an approximate 10% rate of treatment-related mortality. And some of this is related to GI toxicity associated with this very intensively myelosuppressive regimen, which has in other studies also been associated with a significant rate of treatment-related mortality, even in experienced centers. So this is important to keep in mind when deciding which preparative regimen to use. The TBC regimen is very effective, but associated with significant toxicity, including treatment-related death. One of the achievements of the PRECIS study was they were able to demonstrate markedly improved neurocognitive endpoints in a variety of domains among patients that received the autologous stem cell transplant arm compared to whole brain radiotherapy, both in terms of the MDRS score, the mini mental status score, the trail making tests, and they were able to show that after autologous stem cell transplant, at least half the patients showed improvement in the test scores, where after whole brain radiotherapy, more than half the patients went on to show ongoing declines in these test scores, showing consistent with the idea that the toxicity of whole brain radiotherapy is ongoing, and the injury to the brain is likely irreversible. This is not. There's no evidence for this with the autologous stem cell transplant approach. So conclusions: the efficacy endpoint in the PRECIS study strongly favors autologous stem cell transplant, both in terms of event-free and overall survival. The neurocognitive tests demonstrate improved cognitive outcomes with autologous stem cell transplant. The ILSD32 data presented in Lancet and in follow-up form earlier this year showed improvements in survival with autologous stem cell transplant compared to whole brain radiotherapy as well. In the ILSD32, they showed very promising results with the BCNU thiotepa preparative regimen for autologous stem cell transplant, and encouraging results have also been described in CLV 50202 and in the community with etoposide ARC without autologous stem cell transplant. Our group has also published in Clinical Cancer Research by encouraging data with etoposide ARC consolidation after MTR induction. So these are all effective consolidation regimens that avoid the use of whole brain radiotherapy. Finally, it's important to note that TBC is associated with some GI toxicity, and therefore we recommend its use exclusively in centers experienced with its toxicities and management of these patients. Last year, Tracy Batchelor has presented data in unpublished forms thus far on Alliance 51101, which is a randomized phase 2 trial of myeloablative versus non-myeloablative chemotherapy for newly diagnosed primary central nervous system lymphoma. This is here immunocompetent patients aged 18 to 75 went on to receive MTR induction followed with high-dose Ara-C. High-dose Ara-C has the advantage of it was applied in both arms. It's important to note the high-dose Ara-C has CNS is associated with significant CNS penetration, is highly active in intraocular lymphoma, and has been associated with a survival benefit in an earlier ILSG study led by Andres Ferreri. So patients that had stable disease or better after MTRA induction went on to receive BCNU thiotepa based myeloablative consolidation or non-myeloablative consolidation with etoposide Ara-C. The randomization step was was determined at the time of diagnosis before entry onto the trial. The results of the trial showed that in a secondary analysis evaluating those patients that went on to receive consolidation, that there was a slight but not statistically significant advantage in terms of progression-free survival from the start of consolidation for those patients that received a autologous stem cell transplant, PCNU and thiotepa, compared to those that received non-myeloablative consolidation. Overall survival curves were virtually identical in lines 51101, so there doesn't seem to be any evidence of any survival advantage with these two approaches, non-myeloablative versus myeloablative. There's a trend, to summarize the results, there's a trend in progression-free survival favoring the myeloablative arm. However, one of the caveats in this is that there was a significant difference in progression-free survival during the MTR induction between the two arms, which favored the myeloablative therapy arm that could have impacted the interpretation of the results. There's no difference in overall survival between non-myeloablative and myeloablative therapy, and it's important to note that 20% of patients that went on to induction progressed during this phase. So to conclude these preliminary results from 51101 randomized phase 2 trial, both consolidations appear to be safe and actually to yield outstanding results in terms of progression-free and overall survival. The overall survival in this trial is actually quite significant and commendable, in my opinion. The results highlight the need for improvements during induction, however. So one of the challenges in primary central nervous system lymphoma is that the disease incidence continues to increase in persons age greater than 65. And these are patients that are not really good candidates for dose-intensive consolidation, particularly those patients over 75 years of age who are generally excluded from dose-intensive consolidation approaches, including bone marrow transplant. And their outcomes generally are quite poor. Older patients that don't receive consolidation tend to have early progressions and to succumb to the disease within 2 years. In the NSF GOLEMS randomized phase 2 trial led by Antonio Mura, the median progression-free survival for these patients was 7 months. And here the patients receive either methotrexate, procarbazine, vincristine, and cytarabine versus methotrexate and temozolomide. So there really is a dire need to improve outcomes for this older patient population who are not good candidates for dose-intensive consolidation after methotrexate-based induction. So why is the incidence of this disease increasing in older patients? One possibility is, as we get older, mutations in the DNA accumulate over time as our normal B lymphocytes are exposed chronically to antigens and undergo somatic hypermutation to adapt to provide adaptive immunity in terms of the generation of novel antibodies. But also, lymphocyte function decreases as a consequence of aging. So primary central nervous system lymphoma in the elderly may be a consequence of immunosenescence. And this is some work done by Ed Getzel at UCSF several years ago showed that older patients have less have lower performing T lymphocytes in their peripheral blood than younger patients, both in terms of cytokine production and in terms of their ability to chemotax or migrate in response to chemotactic factors. So they're less vigorous, less their athletic performance, if you will, is less effective, and this it may be associated with inability to eradicate pathogens and increased risk for infections and cancer as we get older. So, but one of Ed Getzel's discoveries was that low doses of the immunomodulatory drug lenalidomide was able to rehabilitate or to stimulate improvement in cytokine production and chemotactic responses in T cells from older patients aged greater than 65. And lenalidomide was able to enhance the proliferation and generation of interferon gamma in these stimulated T cells from older patients and restored T cell chemotactic responses. So these T cells were able to migrate better in response to well-established and important chemokines such as CCL21 and CYP1P. And so, well, that's one of the reasons we became interested in the potential role of lenalidomide in this disease. And based upon some early clinical experience, which is promising, we developed a phase 1 trial to study lenalidomide in relapsed CNS lymphomas, both primary and secondary CNS lymphomas. We demonstrated that lenalidomide penetrates the CSF space in a dose-dependent manner, but showed that doses as low as 10 milligrams a day reproducibly were associated with CNS penetration, as assessed by the concentration of lenalidomide in the CSF compartment. And lenalidomide at doses of 15 to 20 milligrams a day showed at least a 20% CSF blood partition coefficient. So we also demonstrated using repeat CSF evaluations of T cells, CD4 and CD8 T cells. We showed that administration of oral lenalidomide in CNS lymphoma patients was associated with a time-dependent and reversible expansion of CD8 and CD4 cells in ventricular CSF, as shown by flow cytometry plots, which showed by day 21 there was a marked increase in both CD8 and CD4 cells in the spinal fluid of these patients, and these in two different patients, in multiple different patients we were able to show this, but by when the patients stopped lenalidomide by day 21, the number of T cells decreased, but repeat administration of lenalidomide was associated with expansion of cytotoxic T cells in the CSF compartment. And we also showed that lenalidomide maintenance after in highly refractory patients, after patients are salvaged with repeat administration of high-dose methotrexate or focal radiation, and then are provided, and then lenalidomide is provided at low doses of only 5 to 10 milligrams a day. Rechallenge of these salvaged patients with lenalidomide was associated with at least a 5-fold increase in progression-free survival compared to or a time to progression compared to their best time to progression without lenalidomide. So lenalidomide was associated with a marked improvement in progression-free survival in highly refractory patients. And analysis of lenalidomide maintenance after MTR induction in patients aged greater than 70 was also associated with a marked improvement in progression-free survival, not reached in patients aged greater than 70 and in overall survival. So the lenalidomide, low-dose lenalidomide is feasible in older patients and is associated with promising evidence for enhancement of progression-free survival in this patient population that is highly challenging and who are not good candidates for dose-intensive consolidation. So lenalidomide is being studied currently by Alvaro Alencar in Alliance 51901 in newly diagnosed primary CNS lymphoma. This is focusing on non-transplant eligible older patients that can't get a bone marrow transplant or not eligible for full-dose EA consolidation. So these are the patients that normally are neglected in clinical trials. And this trial is successfully accruing in a multi-center alliance study, and here lenalidomide is incorporated within the induction in lieu of temozolomide in combination with methotrexate and rituximab, and patients that have some disease control with during induction go on to lenalidomide and ultimately to nivolumab maintenance. This is a highly rigorous phase 1 trial evaluating the different doses of lenalidomide and its safety in terms of its incorporation with these standard drugs, methotrexate and rituximab, and also its safety in combination with lenalidomide, in combination with nivolumab as maintenance in these older patients. The rationale for nivolumab is based upon data that the immune checkpoint molecule PDL1 is upregulated in primary CNS lymphoma, likely as a consequence of a subset of patients that have a 9p24 copy number gain. 9p24 is the genomic locus that encodes PDL1. We've also shown that methotrexate is likely effective in CNS lymphoma because it is not associated with significant T cell depletion, unlike other cytotoxic chemotherapies. We demonstrated this in the setting of AIDS-related primary CNS lymphoma. AIDS-related primary CNS lymphoma is associated with a very low CD4 count at the time of diagnosis, typically less than 50. So these patients generally have advanced AIDS and often have multiple prior opportunistic infections. The cornerstone of treatment in this disease, we believe, still is high-dose methotrexate. We're able to show that high-dose methotrexate can be administered in combination with combination antiretroviral therapy, and we showed that combination antiretroviral therapy, or CR, was associated with improvements in CD4 cells count numbers during high-dose methotrexate induction. So CD4 counts can increase during methotrexate. This is important because this is critical, likely, to the disease control with antiretroviral therapy. So antiretroviral therapy is not only associated with a decrease in viral load, but it also improvements in CD4 counts, and we observe highly promising efficacy when in this neuro-oncology paper published in 2017 when a CR was combined with high-dose methotrexate up front. We also studying other IMiDs in this disease, including the next generation cereblon antagonist CC122, which we showed in a phase 1 study has activity in relapsed primary central nervous system lymphoma patients, as demonstrated by these sequences of contrast enhancing MRIs on. So another challenging case is illustrated in this slide. This is a 74-year-old patient treated last year who had primary refractory CNS lymphoma disease. These lesions were not were actually growing in the face of after 2 cycles of high-dose methotrexate. The patient was symptomatic with hemiparesis and was requiring high doses of steroids. You can see the lesions actually increase in terms of their volume with central necrosis and increasing increasing evidence for increasing mass effect with that compression of this lateral ventricle. So this is a very serious situation. What do we do after MTR induction? The 74-year-old patient is not likely to tolerate whole brain radiotherapy. What are the treatment options that one might consider? Matrix chemotherapy, which is a very effective active induction, but also toxic, combining diatepa with Ara-C and methotrexate and rituximab. It's one option. It's more aggressive than the MTR induction, certainly. Dose-intensive chemotherapy, which is just etoposide Ara-C or bone marrow transplant. Ibrutinib, whole brain radiotherapy, which we discussed earlier, is not likely to be safe given the patient's age, or focal radiotherapy. So focal radiotherapy is an intervention that we've studied in primary CNS lymphoma, described in abstract form at the Society for Neuro-Oncology. This is actually applied in this patient and was effective in cytoreduction of disease. The patient went on to continue methotrexate-based induction and is currently maintained on lenalidomide maintenance. Another case of relapsed CNS lymphoma. This is after 1 year after EA consolidation. This patient presented with multifocal evidence of multifocal disease. So this patient has now 1 year post induction with MTR. What are the options for this 59-year-old patient, slightly younger, younger than 60, but still at high risk for neurotoxicity? Whole brain radiotherapy, matrix chemotherapy, dose-intensive salvage chemotherapy, ibrutinib, or high-dose methotrexate. Here we administered ibrutinib on the basis of some early phase data showing the safety of combination of ibrutinib plus methotrexate in this setting. And this is it's important to note that when ibrutinib is provided to patients with primary central nervous system lymphoma, particularly those patients that have received steroids or dexamethasone, it's important to provide antifungal coverage because of the association of ibrutinib with increased risk for fungal infections, including CNS aspergillosis. So ibrutinib can be administered safely, we believe, when provided in combination with Cresemba or acylfluconazole sulfate. So the take-home points of my talk is that primary central nervous system lymphoma is a potentially curable disease, particularly with dose-intensive chemotherapy-based consolidation, as demonstrated in multiple clinical trials, such as the PRECIS study, the ILSG32 study, CLSB 50202, and now Alliance 51101. Long-term neurotoxicity is a major issue with whole brain radiotherapy at standard doses and at low doses in older patients. Dose-intensive consolidation is standard. Etoposide ARC is one non-myeloablative approach, and there are multiple myeloablative regimens that have been studied as well. Biological therapies represent important tools that can be used to consolidate responses, and it can be incorporated during consolidation or upfront during induction. There's an emerging role for genomics at the time of diagnosis, as well as circulating tumor DNA. And there may be a potential role for CAR T-cell therapy, although data is very early in this realm. Thank you for your attention, and I look forward to questions during the session. Thank you very much.